I'm so glad you're joining me today because we are diving straight into a truly fascinating medical mystery drawn directly from Harrison's Principles of Internal Medicine. We're going to explore a condition where the body's microscopic factories essentially go haywire, but in a very specific and honestly very dangerous way.
Right off the bat, let's look at this high-stakes clinical question. Why could treating a simple anemia sometimes cause irreversible brain damage? I know, it sounds totally counterintuitive, right? You'd assume that correcting a patient's low blood count is always the right move. But as we're going to uncover today, there is a dangerous metabolic trap here. If you give the wrong treatment, you can actually fix the blood entirely while quietly allowing permanent neurological destruction to happen behind the scenes. We'll circle back to exactly how this bait-and-switch happens in just a bit.
Here's our roadmap for today. 1. The megaloblastic mystery. 2. Pathophysiology, or the molecular maze. 3. The B12 versus folate divide. 4. Clinical clues and diagnostics. And 5. Targeted treatment protocols.
Let's kick things off with Part 1, the megaloblastic mystery.
Now, the absolute crucial thing to grasp here is that this isn't just your standard low red blood cell count situation. It's a fundamental failure in the actual construction of the cells. Megaloblastic anemia is a macrocytic anemia, meaning the cells themselves are abnormally large, and this is driven by one core defect, impaired DNA synthesis. Because the DNA literally cannot replicate properly, the bone marrow just starts churning out these massive, structurally flawed, immature red cell precursors called megaloblasts. It's basically like a factory assembling cars with giant, oversized chassis, but totally forgetting to put the engines in.
And you can spot this super easily on a routine lab test. If you glance at a patient's full blood count, you're going to see a markedly elevated mean corpuscular volume, or MCV. Now, a normal red blood cell volume is going to be well under 100 femtoliters. But here, the MCV pushes right past 100, and very often it spikes over 110 femtoliters. The cells are simply way too large.
Which brings us naturally to Section 2, Pathophysiology, the molecular maze.
So you're probably wondering, what exactly is going wrong inside the cell to make it swell up like that? Why does a problem with DNA synthesis create giant cells instead of just producing fewer normal-sized ones? Well, it all comes down to a catastrophic miscommunication within the cell itself.
The formal, textbook term for this is nuclear cytoplasmic asynchrony. Here's what's happening. Vitamin B12 and folate are absolutely essential cofactors for synthesizing DNA. Without them, the nucleus, which is the vault holding that DNA, gets completely stuck. It can't mature. But the rest of the cell, the cytoplasm, relies on RNA and protein synthesis, which doesn't need those specific vitamins in the same way. So the cytoplasm just keeps doing its thing. It keeps synthesizing proteins, keeps building RNA, and grows larger and larger. The cell body is swelling, but the nucleus is fundamentally paralyzed. You get this giant, asynchronous, totally useless cell.
Let's trace that exact biochemical chain reaction because the details here are fascinating. Step 1 is impaired thymidylate synthesis. Because those cofactors are missing, the conversion of DUMP to DTMP just fails. That leads directly to Step 2, defective DNA replication. The cell is literally missing the T in its ACGT genetic code. It simply cannot copy its own blueprint. This triggers Step 3, cell cycle arrest at the S phase, the synthesis phase. The cell's internal quality control senses that the DNA is defective and just yanks the emergency brake. Finally, Step 4. Because these arrested, oversized cells are essentially duds, the bone marrow triggers intramedullary hemolysis. It recognizes they're faulty and destroys them before they ever reach the bloodstream. So you don't just get anemia, you get pancytopenia, a dangerous, across-the-board drop in all your blood cell lines.
And this really illustrates how that one single, microscopic failure, impaired DNA synthesis, radiates outward. It's the central villain of the entire disease, causing that nuclear cytoplasmic asynchrony, the megaloblast formation, the skyrocketing MCV, the hemolysis, and ultimately severe pancytopenia.
Let's move into Section 3, the B12 versus folate divide.
While both B12 and folate are the essential cofactors we just talked about, and a lack of either gives you the exact same giant cells in the blood, their pathways through the human body are completely different. Vitamin B12 has this incredibly complex absorption journey. It actually requires intrinsic factor from the stomach and is specifically absorbed way down in the terminal ileum. And crucially, a lack of B12 causes unique, severe neurological damage. Folate, on the other hand, is heavily involved in purine and thymidylate synthesis, but our bodies have very limited stores of it. You can actually deplete your body's folate in just a matter of months, whereas your B12 stores can literally last for years.
Because of that, the root causes of these deficiencies sharply divide them. For B12, we're very often looking at pernicious anemia, which is an autoimmune disease that destroys the cells making intrinsic factor. But it can also be caused by gastric surgery, a strict vegan diet without any supplementation, Crohn's disease, or, remarkably, even a specific tapeworm called Diphyllobothrium latum. For folate, the causes are usually driven by high demand or poor intake. We're talking poor dietary intake, alcoholism, the massive nutritional demand of pregnancy, or specific drugs that inhibit DNA synthesis like methotrexate.
All right, Section 4, Clinical Clues and Diagnostics. Let's talk about what this looks like in an actual patient.
When a patient walks into the clinic, both deficiencies will present with shared hematological signs. You'll see fatigue, pallor, a sore, beefy red tongue known as glossitis, and maybe some mild jaundice from all that bone marrow hemolysis we discussed. Both can also cause massive cardiovascular strain, even leading to high-output cardiac failure. But here is the critical, glaring difference: the neurological symptoms. B12 deficiency uniquely attacks the nervous system. It causes subacute combined degeneration of the spinal cord. It demyelinates the dorsal columns and cortical spinal tracts. That leads to a loss of vibration sense, a loss of proprioception, and eventually, profound cognitive decline.
So, with such perfectly overlapping blood symptoms but vastly different neurological risks, how do we definitively differentiate B12 and folate deficiencies? We definitely don't guess. We have to look for highly specific microscopic clues.
The first major clue comes from just looking at a blood film under the microscope. If you spot hypersegmented neutrophils, these are white blood cells with more than 5 nuclear lobes. That is a massive pathognomonic red flag for megaloblastic anemia. It proves that the DNA synthesis defect is affecting all the cell lines, not just the red blood cells. To firmly split the two apart, we turn to metabolic byproducts in the blood. Homocysteine will be elevated in both B12 and folate deficiencies, so that doesn't help us choose. But methylmalonic acid, or MMA, is exclusively elevated in B12 deficiency. So if you see elevated MMA, you know for sure you are dealing with B12. And to go one step further, if you test for anti-intrinsic factor antibodies and they come back positive, you've just confirmed pernicious anemia as the specific cause.
Finally, Section 5, Targeted Treatment Protocols.
Remember that crazy question I asked right at the beginning? How fixing a patient's anemia could actually cause irreversible brain damage? Well, here's the answer. Harrison's lays out a strict golden rule. Always exclude B12 deficiency before initiating folate therapy. Why? Because if your patient is actually deficient in B12 and you mistakenly give them heavy doses of folate, the folate bypasses that metabolic block we talked about, it completely restarts DNA synthesis and fixes the anemia. The blood will look perfectly 100% normal again. But, and this is the terrifying part, folate does absolutely nothing to stop the demyelination in the spinal cord. You have successfully masked the B12 deficiency while allowing irreversible neurological destruction to just continue on, completely unchecked.
So once correctly identified, the treatments are entirely different. For B12 deficiency, especially with malabsorption or pernicious anemia, Harrison's protocol requires rigorous intramuscular injections of hydroxycobalamin to just bypass the gut entirely. We do 1 mg IM on alternate days for 2 weeks, and for pernicious anemia, that shifts to lifelong maintenance injections every 2 to 3 months. Folate, however, is easily managed with oral supplementation, usually 5 mg a day for 4 months. We also give 400 micrograms daily preconception to prevent neural tube defects. For both treatments, you've got to monitor the patient super closely. You're waiting for a massive surge in new red blood cells, a reticulocyte crisis, around day 5 to 7. And you really have to watch out for hypokalemia, because as those millions of new cells are created, they suddenly suck a ton of potassium right out of the bloodstream.
We've seen how a tiny microscopic failure in DNA synthesis can snowball into severe, life-threatening systemic disease. But because early recognition is the only way to prevent irreversible myelopathy and brain damage, you really have to wonder how many treatable cases of early cognitive decline or ataxia are sitting out there right now just waiting for the right blood test. Could an unrecognized vitamin deficiency actually be the hidden cause behind early cognitive decline in your next patient?